rewarding to see how well maybe you're doing. So I'm going to talk about neurogenic bladder, and a lot of it related to spina bifida, because that's the most common condition that I think that most of your children and young adults have. I think this is one of my kids went on a canoe trip, and it was a long one across Canada, and it was just a long story, but they started out on their second summer at Lake Winnipeg, and they were paddling up Lake Winnipeg, and suddenly this ice floe came in and surrounded them. And I thought it was a fitting metaphor for what you people face when you have this child that's born with spina bifida and all the problems you have to work through. And so I saw this picture, I thought that's a fitting metaphor for what you have to go through, and I'm amazed at all the challenges that you face and meet as parents and as individuals with this problem. The spina bifida, or biomeningocele, is the most common type of abnormality that we have to deal with in children born with spinal cord abnormalities, but there are some others that have very similar manifestations, including this one called caudal regression, associated with an imperfect anus. So everything's kind of mixed up in the development in the pelvic floor. The incidence of this problem has gone down with folic acid supplements, but it still happens, and there's a range of this problem across the world that is variable, but it's about 1 in 1,000 or 1 in 1,500 in North America, and it's certainly greater in some racial, like the Hispanics, and in North America we know that there was a higher incidence in people of Irish descent, interestingly. I'm going to specifically focus on the urinary tract, because that's my area of specialty, and this condition leads to voiding dysfunction, incontinence, and urinary retention, and this is associated with, well, of course, the social problem of incontinence, but also there can be some consequences such as urinary tract infection and this condition called reflux, or what we would say in common terms, backwash of urine from the bladder up to the kidneys. And this can lead to damage to the kidneys in some individuals. So we really have two goals, and I actually gave this talk when your kids were a lot smaller. And there's another interesting story. Our office was moving recently to a new location, and we had all these old computers, and I lost this talk, but I was sort of opening up some of these old computers to see if there was anything on them, and this talk was on there, so I was very happy to see it, because it saved me doing a lot of work. Although there's a few new things that have come along since I gave this talk, but this hasn't changed. The principles of management. So protect the kidneys, that's our first priority. And then of course the second priority is to promote urinary incontinence, so we can be like other individuals who have good bladder function. And you know that this is a cartoon drawing of the nervous system, and there's a whole complex of innervations from the brain, the cerebellum, the upper spinal cord, and the lower spinal cord that eventually cause us to have good bladder function. And unfortunately, with spinal cord abnormalities, spina bifida included, these nerve pathways are disrupted, and so the bladder misbehaves. It doesn't work normally. And we as urologists look at it in fairly simple terms. We want a bladder that can store urine properly, and we also want it to be able to empty properly. And unfortunately, both things can be mixed up with spinal cord abnormalities. As you know, many of your children and now adults go through this procedure called urodynamic studies. And this is how we help sort out what's going on with the urinary tract. And this was our old room, which I actually like better than the one we have now, which is somewhat cumbersome. But this is, in addition to sort of talking to you and finding out, you know, what you go through day to day, this helps us pinpoint where the problems are and how much risk this puts your eventual bladder function at, and how much risk this puts your kidneys at. So it's a very important test. My grandkids got me into this Pokemon. And they show up on my kitchen table sometimes. Anyway, we're hoping that the Children's Hospital that's coming up, that there'll be a more kid-friendly environment to do this test in, because it really is a frightening, go into this big room with X-ray equipment, and it can be very intimidating and frightening for both the child and the parents. So hopefully we can make it more kid-friendly. You know, we got you know, all sorts of wires hooked up and computers and X-ray equipment, but it can be a challenging test to get through, but it gives us really important information. And eventually we end up with tracings that we can look at both the bladder function and the sphincter function. And usually we give a little bit of dye in the bladder at the same time so that we can see if there's a problem called this reflux problem. And the actual shape of the bladder tells us a lot as to how abnormal or normal that bladder might be. And this is a really abnormal looking bladder with, just gonna slip over this here. So this is the bladder, and it should be a nice round shape. And this one's got this kind of cone shape, and there's a lot of dye going up into the kidney. And this is the first part of the, what we call the urethra, and it's not opening up, it's staying closed. It should start leaking once that bladder gets quite full. And so this is a very worrisome picture for us when we see this.
Is that a full bladder, Paul?
That bladder's quite full, yes. And it's another picture of another a similar bladder. Anyway, if I go back, that's called reflux, because this big area here is actually the kidney lighting up with dye that's gone up backwards up into the kidney. And that's because there's so much pressure in the bladder that it pushes the urine back up into the kidney. And if that's associated with infection, it can cause quite a bit of damage to the kidney. And so we will seek to intervene with fairly aggressive bladder management to avoid kidney damage. So the first thing we'll try is medications, and these are called broad categories called anticholinergics. And you're all familiar with this now. These medications inhibit the bladder muscle from contracting, so it doesn't cause so much pressure inside there. And we've gone through different medications. One's called, the most common one uses oxybutynin, but there are other cousins to that now that are newer developments, and I'll go through that a little bit later. In the past, when the bladder was working fine, but the sphincter wouldn't close properly, and I'll go back to this. I gotta step over this cord.
It keeps you young, that cord.
So this is the sphincter right here. This will be the urethra right here, and this is the sphincter. And that sphincter sometimes doesn't work properly. So the bladder works fine, but the sphincter doesn't work. And so everything just comes out, leaks out very quickly. And this is another category of bladder dysfunction that spina bifida kids and other spinal cord abnormalities can have. And to improve that's a really challenging problem. And in the past, we had some individuals use medications that would stimulate the sphincter to close. Unfortunately, these are the same medications that people take for when they have a cold or a sinus infection. They decompress the blood vessels, but they also help to contract the urethral sphincter. And I'm old enough now that I have a little bit of prostate problem, and if I take cold medication, I have trouble peeing because it closes off my sphincter. And but unfortunately, we can't use these medications for this problem because they cause blood pressure and cardiac arrhythmias. So we're left with other, or forced to use other ways of managing this problem. So going back to the bladder, we want it to store urine properly. And unfortunately, with neurogenic bladder, we can have a spastic bladder because there's nothing in the spinal cord that's sending messages to inhibit the bladder properly. So it just discharges on its own, much like a baby's bladder. Those relaxing nerves never develop properly. And then they end up having, the individual ends up having a poor bladder capacity, and it's something we call compliance. The amount of urine the bladder will hold at a certain volume. And when the compliance is impaired and the bladder won't hold as much, then that's when we start to run into problems with both incontinence and this problem called reflux or hydronephrosis.
Excuse me, Paul, back to the sphincter. There's no surgical interventions at all?
Yes, there are, and I'll go through some of those.
Okay.
Yeah. We can, the main way we improve bladder emptying, as you know, is intermittent catheterization, and also to relax the bladder with these anticholinergic medications. And the person that first introduced this was a guy named Dr. Jack Lapidus in 1972. And this, when I went through medical school in 1974, starting, this was a brand new thing, so it was amazing that someone didn't twig onto this way sooner. But as you know, this is just common, basic, management of neurogenic bladder 101, intermittent catheterization. But it was something new back in 1972. This is a complicated picture or diagram algorithm showing that what can happen when things are really mixed up. And that's when the bladder is contracting, but the sphincter stays closed. And these individuals get into a lot of trouble with poor bladder capacity, what's called hydronephrosis, reflux, and this will cause that problem with kidney function. So when we see these hostile factors in the bladder, we seek to intervene very quickly with intermittent catheterization, what's called anticholinergic medication to relax the bladder, and something that's come along in the last decade is Botox. So when I first went into practice in urology, we didn't have Botox, so we'd have to, if these things didn't work, we would have to do something called a vesicostomy in these babies that had this condition. And a vesicostomy, this is not a great picture, but this is the bladder here, and sort of the urethra going out here. But we'd have to open up the bladder onto the lower abdominal wall and just let it drain it all the time. And we don't have to do that as much anymore because we can be a little more aggressive with anticholinergic medication and this Botox. So if if we do intermittent catheterization with medication, we can achieve a 70 to 80% rate of continence, urinary continence. And if that doesn't work, then we have to move on to other things. So, doc, we're still wet. Can anything be done to fix this? And it's very frustrating. So we can increase the frequency of catheterization. We can increase the dosage of medications and some pediatric urologists and adult urologists will really push the dosage of these medications to try and relax that bladder. The problem is, as many of you know, these medications can have side effects. And you've all seen kids with dry mouth, red face, flushing, other unusual decreased sweating, other side effects. And some of these are intolerable. They're just not, that individual just can't tolerate the medication. So then we can move on to Botox, which I'll talk about a little more in a few minutes. Just to go through some of the medications, oxybutynin, or what we call ditropan, has a long-acting form. So does this medication called Detrol or Totalerine, and another one called Vesicare or Solifenacin. These medications are a little more convenient because you just have to give them once a day rather than the 3 times a day that oxybutynin is administered. However, they may not. Oxybutynin is still one of the most effective anticholinergics available. And our government is a bit sticky about these medications. And they make it challenging to use them. They say, well, you have to give oxybutynin a try first, and then you have to kind of say, well, it's too many side effects, so we want to move on to this one. And they say, well, you have to use this first. There's all kinds of regulations, but these are alternatives that can be used. And another one is a patch called Oxytrol. Now, I must say, we've tried it, and it has an unpredictable success rate, and the patch often causes skin reactions. So, unfortunately, it's not a panacea. It's not an ideal way, but it is one way to administer medication, and a lot of the side effects from these medications. A lot of the side effects from these medications are from the drug being metabolized in the liver, and the metabolites are the agents that cause the side effects. So the patch was one way to try and avoid that because it would go directly into the bloodstream. And the other way that has been tried is to take oxybutynin, make it into a liquid form, and put it inside the bladder directly. So some individuals can put this in with at the time of catheterization 2 or 3 times a day, and it avoids the medication having to go through the liver and avoids some of the side effects. Unfortunately, the preparations are not always that stable, so they're sitting in your fridge and they somehow deteriorate in effectiveness over time, and it's more cumbersome. And I did try this, and a lot of the families just gave up on it because it was just too cumbersome. They couldn't work it out to get it to the school, and they said, no, we're going back to the pills. They work better. We use Botox quite commonly now, and the nurses in the OR always ask me if I could leave a little bit for them. Botox is a toxin, and nerve toxin, and it was actually discovered in the 1850s or during the Napoleonic Wars. A lot of the soldiers died from the food they were served. They used to call it sausage death because it was sausage that they ate and it was contaminated with this Botox. Eventually, this was crystallized into the talk. There's about 8 or 10 toxins that have been identified, but the one that works for that can be isolated and used medically is called botulism toxin A. And through trial and error, it has been determined that a dosage of anywhere from 85 to 300 units in the bladder muscle will effectively paralyze the bladder. And so we mix this compound up, or this substance up, and inject about 30 sites throughout the bladder. And it's really quite straightforward and simple. It's an outpatient procedure. Now in adults, we can sometimes do this without having to give anesthetic. But in children, of course, the anxiety level is quite a bit higher, and we need the individual relaxed, because we have to actually put a scope inside the bladder. But it has been a real addition to the management of neurogenic bladder. And this is sort of a picture of how we do it. I could go through the mechanism of action, but it's actually quite complicated. The nerve, pretend this is a nerve, the end of a nerve, and it's touching the bladder muscle cells. And so when the nerve releases this substance called acetylcholine, hence that's what we call them anticholinergic medications. They inhibit that. But when the nerve releases acetylcholine, it stimulates the bladder muscle. And in neurogenic bladder, there's too much of this. The bladder muscles being overstimulated in many problem cases. And so the toxin inhibits or captures that acetylcholine so it can't be released from the nerve cell. And that's the way it in effect poisons the nerve cells. So it blocks the signal sent from the nerve cell to the muscle cell. This is called a neurotransmitter, and it causes the bladder muscle to relax. Unfortunately, it's not a permanent fix. It does wear off, and it may last in some individuals only 3 months, and other individuals up to 9 months, but probably no longer than 9 months. So if this is going to be used as a treatment measure for neurogenic bladder, it has to be repeated every 6 to 9 months. So that's a bit of a problem. But it's an easy thing to do, and certainly may be preferable than the big surgical options, which I'm just going to go through in a few minutes.
Side effects of having it done often?
Pardon?
Side effects of having it done often?
No. Interestingly, there are very few side effects from Botox, and that's a great question. There have been a few rare allergic reactions to Botox. One was a condition called erythema multiforme. It's a skin eruption, but it's extremely rare. I've never seen it and used it in many cases. And we have never seen a death from Botox in the bladder. Botox, if it paralyzes muscles, it could potentially stop someone from breathing if it gets into your system too much. Never seen it. So the technique is very safe.
So sausage death didn't deter you guys from trying it
No
out?
sausage deaths with the controlled quantity that we use.
And is it completely covered, cost-wise?
Good question. Again, the government says,
Do this, do this, do
do
this.
this, yeah, it says, all right, you have to, and we worked very hard to get this covered for neurogenic bladder. We wrote letters and had campaigns, and but they said, okay, you have to try at least 2 different anticholinergic medications and have failed those. So oxybutynin and say Vesicare. If you fail those 2, then you can use Botox. Yeah.
The people making these decisions, they obviously don't have children that
Yeah.
have
Well,
neurogenic bladders.
you know, why they wouldn't just trust our judgment that we think this is the
That's the part that I don't understand.
best treatment for this individual. I don't know. But that's the rules. And supposedly to stop abuse of the Botox. The cost of one of those units, so we use, it comes in 100 unit vials of Botox. And we use 1 to 3 of those vials. And each one of those vials costs $400. So it can cost $1,200 a treatment if we use the full 300 units, just for the medication.
Therein lies the decision.
Yeah. So we definitely, it's been well documented on both clinically and by urodynamic testing. We improve the capacity, the compliance, and the continence of these individuals. But it may last only 6 to 9 months, and it doesn't always work, unfortunately. So it comes to our next step. And in days when we didn't have Botox and we'd gone through the maximal medical treatment of anticholinergics, intermittent catheterization, and if that didn't work, and we've had this child with a vesicostomy, but now they're getting to the age where they want to be out of their diapers and in underwear, we may have to do something to stop from being wet all the time. So this big operation called augmentation adermocystoplasty is one of the solutions that we can use to fix that problem. We want to make a bigger bladder, and we want to make a bladder that has a low pressure in it. It's a good reservoir to hold urine. But again, the key to this is that we still have to do intermittent catheterization. So just a few pictures. We take a piece of bowel and we take about a 1.5 to 2 feet of the 20 feet of small bowel in there and separate it, put everything back together, and then we have this patch of bowel that we make a big patch out of and sew it into the bladder. And that's the bladder, and that other piece of tissue being sewn onto the bladder is the piece of bowel. So that's called augmentation cystoplasty using small bowel. And that's the most, it's done around the world, and this is the most common way to make the bladder larger surgically. Unfortunately, it's a big operation and it has complications, and it has long-term consequences. And many of you are familiar with those already. Some individuals will have immediate problems of a bowel obstruction or infection, but those can be fixed. We fix those and get people through this. But the long-term problems are mucus production. So that piece of bowel, the bowel works to lubricate food as it runs through, and to do that it has mucus inside it. And this mucus production continues, although it does moderate with time, and it's not as much as at the start of this surgery. Another problem is bladder stones. These can be quite a they'll occur in up to 20 to 30% of augmented bladders. Now, why this happens, it may be a combination of mucus, plus infection, plus maybe it doesn't drain quite as well as it should because of the low pressure in the bladder. And unfortunately, sometimes these individuals still have incontinence. The most serious complications from this augmentation procedure can be a bladder rupture, which can be, if not recognized, can be fatal. And so if an individual with an augmentation suddenly has a lot of abdominal pain and fever and is unwell, we have to look for this bladder rupture and fix it very promptly. And the other long-term risk is there's been a few cancers reported in those bladders. And that is a big concern for us, although unfortunately neurogenic bladder in itself with infection and with irritation is also a higher risk for developing cancer at a later age. But it is a concern, and so we do and we have discussions about this as urologists as to what is the best way to monitor for that problem. Well, certainly if there's a lot of bleeding suddenly, we want to check that individual right away. If there's but I've been making a habit of bringing these individuals back every few years to cystoscope, to look in the bladder, both to make sure there's no more stones developing and also to check for this problem. But it's not agreed upon as internationally that is a worthwhile use of our health dollars, let's say that. But I am a little bit concerned, so I do keep an eye on these bladders.
Paul, the cons tend to outweigh the pros in this whole procedure. Just
Pardon?
listening to the cons, they tend to outweigh the pros in this whole procedure. Why would somebody have this done? Why not just, all right?
Well, here's the pro. So this is a bad bladder right here that didn't respond to Botox or anticholinergics or even catheterization. Those kidneys will get damaged, and so that individual will go into renal failure. And so what happens then? Well, you're on dialysis and looking at a kidney transplant, and still you haven't solved the problem because that kidney transplant won't survive with that bladder. Yeah, it'll do the transplanting as well. So that's, your hand is forced sometimes to do this to preserve the kidney function.
Paul, do you find you're doing less now that Botox has come, so you have...
I don't know,
Okay.
Gene, that's a good question. I think so. But we've only been using Botox for maybe, very routinely for about 5 years
Here.
here. But it may be at the most 8 or 10 years around worldwide. So it hasn't been around that long as a routine, measure. So will this keep working? So far, after 4 or 5 years, it does seem to work. But in 10 years, will it stop working? By repeated Botox injections? That question has not been answered. Okay, it remains to be determined whether Botox will be an effective therapeutic measure, throughout the life. You're looking, 40, 50 years,
How early will you start Botox? What age?
Depends on their blood.
I'll start it at age 3 or 4. Yeah. If that bladder's behaving badly, yeah. So this is an augmented bladder in that same individual, and now it doesn't have any reflux. So it's really helped preserve the kidneys. But it does require active catheterization, with intermittent catheterization, clearing the mucus out, and monitoring for any stones and other problems that might develop. But look, you go from diapers into underwear in many cases, most cases. And you help the kidneys. A few you have been through this, and this is, you know, it's so frustrating when you can't get the catheter in. The procedure called Mitrofanoff has been a very lifesaver for many individuals who have this problem with catheterization. And also, there can be orthopedic or physical problems that preclude someone doing self-intermittent catheterization. And you know, when your kids get to be 10, 11, 12, they want to be on their own. They don't want mom and dad always, you know, having to do the catheterization. And so this is another way that individuals can become independent with catheterization. And, you know, so the indications, sometimes individuals are not born with a proper urethra to catheterize, orthopedic problems. Some individuals just don't have the dexterity to get, you know, into that area well enough. And some individuals actually, and this usually doesn't apply to the spina bifida group, but there are other bladder dysfunctions where the urethra still has normal sensation, and because it hurts to catheterize, these individuals won't catheterize themselves. And so we give them a Mitrofanoff, it's called, an abdominal channel that they can catheterize a bladder that doesn't have much sensation. It's much easier. And this guy was a genius. His name was Mitrofanoff. And he just decided he saw the appendix sitting there one day, and he said, you know, I'm going to try and see if I can plug this into the bladder and use that to catheterize. And he did 16 kids. And he would close the bladder neck so they wouldn't leak through the urethra. And he had pretty good results, although some of those he had to take back and do bladder augmentation because they would be incontinent through this Mitrofanoff. So he realized that you also have to solve the bladder pressure problem and not just catheterize. So but anyway, he's a hero in the urologic world, this guy, Mitrofanoff, for having figured this out. And everybody says, well, why didn't I think of that? I could have been famous. Anyway, this is just some pictures. There's the appendix coming off what's called the cecum, and you preserve the blood flow to it, and it's got the right caliber to catheterize, about a 12 to 14 French. So that was one, but sometimes the appendix is just not available, and so this is just showing how we incorporate it into the bladder and then bring it up through the abdominal wall, often the umbilicus. So this is one individual I had who wouldn't catheterize per urethra because it hurt too much, and his kidneys were getting in trouble. And so we did this procedure, and I remember him coming back to the office and says, Doc, this is the best. It doesn't hurt anymore. And yeah, he's so happy. It worked quite well for him. His abdominal wall doesn't look that pretty, but the site of the stoma is right at his belly button, umbilicus. There's other kind of tubes that have been used for this procedure when the appendix is not available. And sometimes we use a little piece of the small bowel to make the tube. It's called a Monty tube. Anyway, this is just another way of doing the Mitrofanoff procedure.
Wouldn't you have that mucus and stuff that you have?
What's that?
Would you have the mucus and stuff problem then?
A little
Like
bit of small ball?
No, you don't, but most of these individuals will also have the augmentation done as well. And that's what that picture is showing right here. So the first piece of that bowel is for the Mitrofanov tube, and the second piece is for the augmentation. And because, as I said, when this was originally done, a lot of those failed because there's just too much pressure in the bladder. They push urine through the Mitrofanov.
And would you have to replace that tube, Paul, from time to time, or is it fairly?
Well, I'll get to that.
Okay.
Okay. You're way ahead of us,
Oh,
Gene.
sorry.
Sometimes, because individuals are quite, they have a very large abdominal wall, we actually have to make two Monty tubes so this is very challenging, complex surgery sometimes. So here we get to your question. Yeah, about 20% of these over the long term fail, and it's either scarring off at the opening, or there's kinks in it, or the valve mechanism, because we have to construct it into the bladder wall so that it doesn't leak. It's got to have a valve effect in the bladder wall, much like a ureter is not supposed to reflux. And sometimes that tunnel fails, and so the individual still leaks. So over the long term, 20, even up to 30% require revisions or redoing. So we're getting down to one of the last more difficult problems to deal with, and that is when we've got a good bladder now, but the urethra doesn't close properly, and we still leak. So what do we do about that? And this is a challenging issue to deal with, because we don't really have good medications to fix that. Some people have tried injecting bulking agents in the urethra to kind of close it off. They don't work very well. They do work in certain situations. So then we're left with this thing called bladder neck reconstruction. And that can be in the form of completely closing the bladder neck and giving them a Mitrofanov, or some centers put artificial urinary sphincters in. These are problematic because they require quite a bit of dexterity to use. As I said, a lot of individuals with spina bifida don't have that dexterity to manage these. So this is just a picture of bulking agent being put in the urethra. And this is more commonly used in girls than boys. In boys, it just doesn't work at all. This is called what we call a sling. We take a piece of tissue from the abdominal wall or some artificial material and pass it around. I'll go over here again. So this is the bladder, and this is the urethra going out through either the penis or the vagina, and we put this sling material underneath the urethra and tighten it up that way. That's called a pubovaginal sling. This works fairly well for girls. It doesn't work for boys that well. So there's other fancy bladder neck reconstructions that are done. They're very complex. This is a kind of a circular cuff that goes around the urethra below the bladder, and it's got tubing that goes to a reservoir and another piece of tubing that goes to a valve that is placed in the scrotum or in the labia of the female, and this is used to close the bladder off when you're not ready to void, and then it has to be decompressed when the individual either wants to catheterize or void. Now, I don't have the expertise to do this, and it's not used that commonly in spina bifida kids. There's all sorts of other things that have been tried, as you know. There's a lot of research going on in stem cell nerve generation to improve spinal cord function. There's also stem cell research going on to make bladder tissue. So that, if that ever worked, we would be able to get away from this augmentation operation. And so far, there just hasn't been enough success to use this in the real world. I can't, clean air catheterization is still the main pivotal mechanism of managing the neurogenic bladder. Yeah, I had a great fun with my grandkids this summer catching pokies. I think that's the end of it. Questions? We've asked a few already, great questions. Must have answered them all, right?
What percentage of your spina bifida caseload would actually have had or consider the Botox?
I think it's a bit of a moving target right now as popularity sort of increases. But I would say 20 to 30%. Yeah, it's that group that doesn't respond to medication and intermittent catheterization. So still 70% or 80% will do fine with just medication and intermittent catheterization. Yeah. Yeah.
I'm I'm fascinated by the amount, like you say, just the CIC, the cathing, how well it works, but how many of the new families aren't consistent with that. They'll do twice a day, or it's just so fascinating to me. It's such a simple solution, and just do it regularly, but they just, I don't know. I don't know if it's the way I'm delivering the message or what it is.
When they come to the clinic, is that what you're hearing?
Yeah.
Oh,
You see, you're probably talking to the computer.
I know, this
You
is the
see
wrong crowd. but
People that show up
exactly.
to get educated
I know.
and
Yeah.
look into things.
Yeah,
Well, I think the one
I
thing
find
that stuck
that
with me when Christine was little was,
Yeah.
like we're saying, this is the one thing, the kids.
and we preach that, like it's the kidneys, you're preserving those kidneys, but it's just, I find that fascinating.
Yeah. Unfortunately, there's so much family dysfunction,
I think, yes.
and people can't remember to take their own medication, let alone
Yeah.
help their child out.
Yeah,
And so, yeah, it's the most frustrating thing when that is the most important aspect of management. Yeah.
and it is, and just the whole coming to clinic, you need to get your renal ultrasound done, and then you don't get your blood work, but so many don't get that done.
Paul, did the medical community get together with, say, the engineering community to discuss ways perhaps of designing, a good example is the shunt tubing that was designed by an engineer initially to drain fluid off the brain, the same idea with the sphincter
Yeah,
of the
well,
bladder?
there are lots of collaborations.
Mhm.
I haven't been involved with any engineering people, but across the world, there's lots of pediatric urologists that will be in collaboration with bioengineers and to design better products. The catheters have improved over time, although Darcy Cadu out in Edmonton did a study on the good old catheters that we used for years and years and comparing them to the modern lubricated single-use catheters, and didn't find a great difference in the rate of infections or rate of problems related to catheterization. But I think there's been quite an improvement in compliance with lubricated catheters.
Oh, yeah, absolutely.
Yeah.
And I think for independence too, when I think those long things we used to use and run iodine through them to wash them, oh my heavens, like I can't imagine someone having to do that at school or,
Yeah.
Yeah. The other issue that's come up, and it's not, well, it may become an issue, but it is an issue in some larger centers. It's called transitional care. So that's when kids turn 18 and they're no longer
Oh,
able to go to a multidisciplinary clinic like the one that runs here. And so then they're sort of tossed out into the adult world of care. And that can be very sketchy in some places. Even a place like Toronto, you know, the amazing care at Sick Kids Hospital. And then they turn 18 and off you go. And some of these individuals have to find their way around the adult world, and it's not always that friendly or that
Easy to access.
comprehensive care. And because there's been fairly good urinary tract management, that's contributed to a long lifespan for people with spina bifida, because that wasn't the case 30 or 40 years ago. And so all kinds of issues are showing up in adults, one of them being kidney stones and bladder, and these bladder stones. But kidney stones are a lot harder to clear in neurogenic bladder patients than in other people with kidney stones. So, and other issues that need to be addressed in the adult. So anyway, it's a concern, and steps are being taken to address it actually in most places now, because it's recognized as a problem.
The multidisciplinary clinic you need like to have.
Yes, or at least
Have urology.
transitioning to people that understand the problems that can develop. So understand what augmentation cystoplasty is. Understand what anticholinergic medications are required, and the problems that can be associated with catheterization, intermittent catheterization. Because that's been recognized as a problem, and it's being addressed.
So speaking of transition, Paul, can I ask you a question? I know you're getting to be like my age and stuff, I'm getting older, and
Yeah.
eventually sometime you're gonna step aside. Is there somebody within your
Right,
group
so-
that,
Right now, in our practice, we don't really have another reconstructive urologist. But as we speak, there is a resident training that is going to do a fellowship in reconstructive urology. And so that will include the augments and neurogenic bladder management. And he wants to come back to Saskatoon. So that's great.
so you have to wait then? okay?
And we have a new pediatric urologist. Her name is Ma. I don't know if some of you have met her already.
What is her name, sorry?
Alka Ma, M-A-U. She's a tall Norwegian lady. It sounds oriental. or
Yeah.
Asian. She's been coming to the clinics, and she's going to take over as well. All right.
I feel this, our association, people, a lot of them are getting educated. Is there a way that our association can help educate some of the ones that aren't as consistent?
You offer these days.
Yeah, we offer these days, but is there more that we can do?
Especially where they live, like, over at Cheshire, nobody knows, there's no nursing, and the Ministry of Social Services won't do that, but there is a need for education over there, like for staff even,
Even
like
young
in here.
families.
And we have a website too.
If
We
we-
have our own website.
Yeah, we're gonna put
Thanks
this on.
today, we have a website, so maybe we should have some stuff on the website.
I just see success amongst most of our members
Huge.
compared to
Then you get,
So
then
did
they,
the
you-
other. and
but then
I
they
think
move
if
out
we
and
can-
there's issues,
If we can help somewhere along the way, and sure, we have our own problems with our own kids, that's enough. But if there isn't, it's just our experience will help and not have to put too much into it.
Yeah, again, it's a matter of resources.
Yeah.
And, Lynn does her best, but her time is split in so many different ways. But, more time could be spent with educating parents, that's
Yeah.
for sure.
And there is 3 families that really wanted to be here today, and that's who's texting me. Take
Oh.
take good notes, but we've got it taped and we're gonna put it on our website, so,
Great.
you know,
Um,
there are some.
Yeah, so,
that couldn't come.
and, you know, there's lots of families up north that just don't have the same
Yeah.
Yeah,
access to education, to
service.
Yeah.
you know, just the follow-up, they just can't get it.
Oh.
Where you know, emphasize the importance of all these things and monitor that these things are being done properly. They fall through the cracks,
Suffer.
and it's very frustrating. But I can't make a trip up north every week either, or anything like that. I'm too busy working here. But that's, you know, somebody traveling up north to see these families, you know, to check in and maybe even go to their homes and see,
Yeah.
you know, what kind of facilities they have.
Yeah.
Is there home
What's
care
happening
in
at the school. It's very frustrating.
So resources would help a lot,
Yeah.
I would think.
Is there home care in those communities?
And I think
Is
too,
there-
that's one thing we've tried to do is partner, like even with the health nurses up in the clinics up there, and they've been quite good, and, you know, we tried to build that relationship, and you're right with the schools, you just have to build that relationship. But truly, like he said, like the nurse that's associated with the clinic, it's not, like, that's not all your job, and like, that's kind of been taken away from me, and it's just I'm coordinating the clinic and kind of do it that day. But it's, oh my God, like if she could just, like Dr. Mao, the new one coming in, you could just work with her and do all that. Like a nurse coordinating, that could just be so amazing.
You know, and I think with the Children's Hospital coming on stream,
That might help.
that facility should have a full
Yes.
functioning urodynamic unit.
Yes.
And.
Is it gonna?
No,
No.
yeah.
Oh, how much does that cost?
You know, and it should have a, like I said, a kid-friendly environment.
Yeah.
And a place where a nurse, a fully dedicated or pediatric urology nurse works.
Yeah.
So Lynn does that only part-time, because she's got
Yeah.
all sorts of other people that she has to deal with. But there should be a pediatric urology nurse that helps families with
Yes.
catheterization and education, and is able to phone them up every week or every month or so to
See how
check
it's
up
going,
and see how
yeah.
things are going.
Are they doing it?
But is there more of a move towards that, do you think, Lynn? Like, we're working peds, and now we've got a dedicated respirology nurse, there's a dedicated pediatric rheumatogy nurse,
And the
there's always been a
G2, the
neurology, there's a
G2.
G2 nurse. Like, I wonder if
Okay, so
with
why
more.
Yeah, why is it,
why do we get left
Yeah.
out?
You read
Pick up
letters for,
Pick up a
yeah.
class.
I will.
No, but we can write a letter to the Ministry
Yeah.
of Health and say, hey,
Yeah.
some more
This
pediatric
is part of
urology
where
money.
the question's
Yeah.
coming.
Yeah.
Can we help with pushing? I
See,
mean,
there's an association called PUNS, Pediatric Urology
Nurses
Nurses
Association.
Association. And the benefit of that is that these people get together once or twice a year and they network and they find out what works for their group of kids and what doesn't, and they get all kinds of ideas. And they email each other all the time, and, you know,